Low back pain is a near universal human experience, with roughly 84% of us feeling it at some point in our lives. While most episodes resolve within a month, a small percentage of cases deviate from the expected path, persisting for years as a chronic condition. Historically, we've treated the spine like a mechanical support column. If there is pain, we assume there is a broken part, a slipped disc, or a fractured vertebra, acting as a faulty component in the machine. But this mechanical model has a significant flaw. In many patients, the pain remains long after the physical tissue has technically healed, and the broken part should be functional again. This is a comparison of two routine MRI scans. The first shows severe disc degeneration in a patient with zero pain, while the second shows a structurally pristine spine in a patient suffering from debilitating chronic agony. These clinical findings suggest that what we see on a standard scan often fails to correlate with the intensity of what the patient actually feels. Solving this mystery requires us to look closer than an MRI can see, and then zoom out much further than a typical orthopedic exam. We have to investigate the problem as a sequence of biological and environmental events that move far beyond simple structural damage. The healthy disc core is devoid of blood vessels and nerves. When disrupted, the body reacts with inflammatory cytokines. Pathological blood vessels and pain-sensing nerves then grow deep into the isolated center. This neo-innervation physically hardwires the tissue to send continuous distress signals. By this stage, the disc functions as a chemically sensitized pain generator, capable of transmitting nociceptive signals even without a heavy mechanical load. At the biomechanical level, we find the paraspinal muscles, specifically the multifidus. These act as the spine's primary support scaffolding, stabilizing the vertebrae during movement. In response to pain, the brain initiates a protective shutdown of these stabilizers. The muscles rapidly atrophy and fill with fat, losing their ability to support the spine's weight. Studies show that this muscular dysfunction and fatty infiltration often persist long after the initial pain episode has resolved. Without this support scaffolding, the spine's load distribution shifts. This places concentrated mechanical pressure on the lower discs, creating a cycle that keeps the underlying tissue in a state of constant irritation. Finally, we must zoom out to the macro level, the patient's life and environment. This is the biopsychosocial model, where modern medicine looks for the non-physical drivers of pain. Clinicians look for yellow flags, such as fear avoidance beliefs. This happens when a patient is so terrified of re-injury that they stop moving, which inadvertently worsens their muscle atrophy. There are also orange flags, like depression, and black flags for workplace stressors, or blue flags for low job control. The brain interprets these compounding stressors as active threats. This keeps the central nervous system in a state of high alert, effectively turning up the volume on any signal coming from the back. This neuropsychological feedback loop prevents the body from exiting the trauma phase, maintaining the perception of pain regardless of how well the tissue has healed. When microscopic sensitization, biomechanical failure, and psychosocial stress overlap, the condition is clinically classified as nonspecific. This accounts for approximately 90% of all chronic cases. This explains why isolated treatments often fail. Prescribing prolonged rest can worsen muscle atrophy, and structural surgery cannot address a nervous system that is stuck on high alert. Successfully treating the condition requires addressing the cellular, muscular, and neurological layers that collectively keep the pain cycle alive. The international consensus for treating nonspecific chronic pain has shifted toward integrated, multidisciplinary rehabilitation. The physical component involves targeted neuromuscular training designed to rebuild the atrophied multifidus and restore the spine's natural load-bearing capacity. Psychologically, cognitive behavioral therapy is used to dismantle fear avoidance beliefs, helping to dial down the nervous system's threat response. Rebuilding the physical support and silencing the nervous system's alarm allows the body to finally move out of the trauma phase, addressing the biological, physical, and psychological reality of the whole person.